of our jejunum. Now we need attention in this picture. This is our duodenum, yeah, which we will study today. Time will be enough. You can see it has four portions. Upper blue one we call superior horizontal. Green one we call descending. This orange, I don't know, pink one, it is the inferior horizontal, and the yellow one, it is ascending. And finally, it is called the flexion. This is the passage place between duodenum and between the jejunum. Now look, your duodenum starting in the level of L3, L1, then it is passed from L1 to L3, descending portion. Inferior horizontal in the level of L3, and then it is come up to the level of L2. And here it is gives the formation of the jejunum. That's a structure number one in my picture. It is flexura duodenum. Structure number two, it is the terminal portion of our ilium. But if I don't mistake, I draw it for you.
You draw, but you don't describe.
That's like, guys, you're crazy. You're absolutely crazy. You are crazy, first of all. If I draw this picture, what it means I didn't draw. If I didn't draw, how Hamza have it?
Doctor, I don't know how we bring it. You can ask for a student, doctor, not just one student.
Let's continue. That's a structure number one. It is the flexura duodenum. Structure number two, it is the iliac second angle. Now between these two structures, I draw two lines. And these two lines in my picture, structure number three, which we call root of the mesentery. This is root of the mesentery of the small intestine. What does it mean? On the posterior wall of the peritoneal cavity, we have the place of attachment of one big ligament. Now imagine that this is posterior wall of the peritoneal cavity. As you remember, ligaments in the peritoneal cavity, it is duplications of the peritoneum. Peritoneum forms the double leg. And these ligaments has three main types. Yeah, it is so-called suspensor ligaments, nutritional ligaments, and remnant ligaments. Now I speak exactly about nutritional ligaments. Nutritional ligaments, which is come from backfold to the organ, we call mesenteries. We have different mesenteries. The mesentery of, for example, small intestine, transverse colon mesentery, sigmoid colon mesentery. After I will show it for you. Now look, mesentery of small intestine started in the primary portion of the jejunum and finished in the terminal portion of the ilium. That's between my two fingers, which you see. I have the root of my mesentery. My upper finger located approximately in the level of the anterior axillary line, level of L2. Because I say you in the L2 level, duodenum become to the jejunum. My right finger located in the level of my right sacroiliac joint. So here root of my mesentery is start, here root of my mesentery is finished. Between them we have 20 centimeters. From this 20 centimeter, now look, the wire shape, it will come from all loops of the small intestine. And will supply all loops of the small intestine. You remember in my previous picture, slideshow, there are the special picture. Mesentery without intestine. Intestine is cutting, but mesentery forms like the curtains, a lot of the folds to reach all the parts of the small intestine and supply. So if I will put now between my two hands these three structures, it will show what is located in your mesentery, artery, veins, and nerves. Of course, uppermost and lowermost points of this mesentery, it is short because they become to the fixed structures. If they come to fixed structure, the way in which they will pass will be short. Middle portion, which is come to the middle part of the small intestine. The small intestine is 4 meters long. For the cadavers, 5 meters long, because muscles is relaxed and the intestine stand little bit more longer. Middle portion receive a long mesentery, 20-25 centimeters. That's a middle portion is very movable. For example, during surgeries, you can take this middle portion of loop and remove from the wound to outside because they have long mesentery. Okay, if it's understandable, let's continue. Now, approximately from midline, draw please this red structure. This red structure, as you understand, it is aorta, and in the level of the rectum, it is the level L4, L5, divided into two terminal branches. By the way, each this terminal branch also divided into two. That's why you will have something like this. Structure number one, of course, it is aorta abdominalis. Second structures, it is the common iliac arteries. Third structures, it is internal iliac arteries. And fourth structure, it is external, which we come to the femoral arteries and supply your lower extremities. As I say, this is the main sources of arterial supply, which we have inside of it.
Doctor, external one is lateral, right? Or medial?
External one, what?
External iliac artery is laterally or medial?
External iliac artery, not lateral and not medial, it is in front. It is come to the lower extremity, I say you before. It is passed behind of your inguinal ligament, approximately
The
midpoint.
name is changed.
And the internal one, it is backside implicated. It is lie on the posterior wall. First we think what about you want to ask, then ask. It is lie in the posterior wall of the pelvis. And it is supply the pelvic structures and give the branches to your gluteal region, please.
You answer.
Thank you very much. That's why I don't like question for question. So if there are the meaning, ask me. Idea is understandable. As I from upwards, you will see the first branch of the aorta abdominalis, which I drew for you last day. It is truncus soleus. Truncus soleus supply approximately all upper compartment except one region. It is the duodenum together with head of the pancreas above the papilla duodenum major. This region supplied by, as you remember, arteria all superior compartment supply. Now look please here, second artery which I drew for you, it is the artery number, it is not one, of course. 1, 2, 3. Sorry, numbers I mixed little. 3, 4, 5, and 6. Prove me if I put them not correct numbers and you don't see me. 1, 2, 3, 4, 5, and 6. Let's say this is structure number 7. In our picture, we call it superior mesenteric artery. Truncus soleus, again I say, you supply all superior compartment, Now, superior mesenteric artery will start to supply inferior, but there are one exception about what I want to say you before, yeah? It is this region. Now you can see that it gives one ascending branch, which is go to upwards. In my picture, it is artery 8. And we call it the inferior pancreatoduodenal artery. You remember, guys, in region of pancreas and duodenum, pay attention to me. This is your stomach pylorus, this is your superior horizontal, descending, inferior horizontal, ascending part, and here we have head of the pancreas. It is continued after by the tail. Let's say for us it's important landmark here, this point. Look, it is papilla duodenum major, border between middle and lower thirds of the descending duodenum. Here we have two vessels. From upwards we have artery 1. We call it pancreatoduodenalis superior. It is from gastroduodenal artery. In your previous picture, if you will open, you will find it. From downwards, we have artery exactly 8, which I draw in the picture. It is pancreatoduodenalis inferior. Let's say these two structures together supply and duodenum and head of the pancreas together.
They understand most or no?
Yeah, of course. Now let's continue. Now look please here, then 7 artery gives huge amount, 10, 14, 15 branches inside of the mesentery of the small intestine. These arteries, all of them together will be the 9 arteries, will be called jejunal or ileal arteries. they will go or to the jejunum or to the ileum. Now attract your attention into this picture. 1 minute, sorry. Into these pictures. By the way, today both these slides you can take. Yeah, it is a large intestine, it is a small intestine, so you can take the both. For example, in this one. This is the small intestine, yeah? Which is connected with its mesentery. Much more better it is visible in this picture. If you will look attractively, what do you see? Uppermost portion mainly have horizontal position. Lower portion mainly have vertical position. Horizontally located jejunum, vertically, but in real case, guys, that is not two countries. Between them, we don't have the official border. One is become to another. And nobody will not say you, yeah, friend, I am jejunum or I am ileum. Let's say this division, it is artificial division. In real case, they little bit differ by diameter. Ileum is little bit bigger. For example, 3.5 centimeter. You know that you make the surgery, all of these intestines is mixed. Peristaltical movement, you will move them, let's say they will not be so beautifully arranged in the peritoneal cavity like you see in the picture. Normally the one is continuation to another. And what do you see? These vessels, as it's showing in this picture, forms the arches inside of the mesentery. By the way, in real case, it is not the 1, 2 arches or 3 like it should, but up to 5. It's up to 5 arches will be formed, something like this. Look, 1, 2, 3. And each one divided into terminal branches. Between terminal branches, the arch is formed. Once again. And like this 4 or 5 times. And finally, you can see that from the last arch, the straight vessels, we call it vasa recta, become exactly to the parts of the intestine and supply them. This gives for us great opportunity. First of all, if by trauma, if by thrombus, if by atherosclerosis, one from these vessels will be closed, supplyment of intestine will not be anyhow changed. Because there are huge amount of the anastomosis. If you want to remove the intestine, for example, there are the tumor, you can make small resections. What does it mean? I can make resection of intestine how much, how I want. Why? Because it has many vessels. I will ligate the vessels, which is, for example, supply the region of my resection and will remove. Now imagine there's another situation. For example, he is some organ. He has only one artery. If this only one artery will be ligated, all these organs should be removed. In case of large intestine, we have such kind of situation. Let's say for large intestine, we cannot make small resections. We can remove big pieces, which we call hemicolectomy. So remember, once again, small and large intestine absolutely differ from each other by specificity of supply. Small intestine take a lot of the vessels, so between all these vessels have the anastomosis. Large one. Now I will show for you, and you will see that there are a few anastomoses and they not enough to normally supply. What does it mean? For example, he is one artery, I am second artery, we supply him, but between us we don't have big anastomosis. If one from us will be closed, one big piece of this intestine will be necrotized, should be removed. Inside of the small intestine, situation another, you see huge amount of anastomosis. Let's say I cannot say now from these 3 arteries which one exactly supply this region. And first and second and third. Because they form between each other a huge amount of anastomosis. Let's continue. Now look at please, next branch of the 7 artery become exactly to the iliocecal angle and discharged in the region of the sickle. It is artery number 10 in our picture. We call it arteria iliocecalis. Arteria iliocecalis. This arteria iliocecalis gives one small branch into the appendix. It is become to the mesenterial appendix, artery 11, which we call arteria appendicularis. Then you make appendectomy. Before removing of appendix, you will ligate this artery inside of mesentery to prevent any bleeding. I think it is understandable. Let's continue. There's an R310, you can write in brackets and remember, supply the sicle, appendix, and iliocecal angle, junction between the sicle and between the terminal portion of the ileum. Let's continue. Next branch of R37, we call it 11.1, right oblique artery. In the Latin we say arteria colica dextra. In the level of the, it is come to the ascending colon from backside. Backside of ascending colon attached to the posterior wall. It doesn't have the peritoneal coverage. Ascending colon is mesoperitoneal. It is covered from three sides, right and left and in front. Posteriorly, it doesn't cover by the peritoneum. On the level of the ascending colon, it is divided into two terminal branches, one to upwards, second to downwards. This down goes structure forms small anastomose with iliocecal artery. Let's draw it by such kind of the star. Yeah? Small anastomose. But what the problem? This anastomose functionally not enough to supply whole one region. What does it mean? Imagine that arteria, for example, iliocecalis here will be ligated. By first point of the view, you think that 11.1 will give the enough blood for supplyment of this region. No, it's not, will not be happening. This region will be necrotizated. You can see, but in that case, why we need to have anastomosis? Guys, anastomosis is divided into two main types. First one, it is anastomosis which is functionally very developed. And if one from two vessels, which is form anastomosis, will be closed, second will supply both regions. And region of first one and region of second one. But it is only exceptional cases. In majority of the cases, we have functionally not so much developed anastomosis. What means? It is provided some additional blood to that region, but cannot compensate its supplyment of another artery if it will be closed. For what you need? You need physical work, or your intestine make the digestion. If it is necessary to increase the supplyment into 10-20%, it can be happen by anastomosis. But if you need to make the, for example, compensation into 100%, another artery is closed. It can. It is impossible. You understand me or not? Let's continue. Now, next artery, which I must to draw here, I will clean this 8.1 and these branches also. It is the artery which is come to transverse colon. This is artery 12 in our picture. We call it the middle colic artery. Middle colic artery. And it's split into two branches. One is goes to the right knee. We call it descending branch. Second is go to the left knee. We call it ascending branch because left knee located higher. And again, I will draw here small anastomosis. But again, it is functionally not developed. And again, if one from these two vessels will be leaked, second will not supply both regions. Let's continue. Open the brackets and write, please. By artery 12 in superior mesenteric artery number 7 is finished. Let's say 12 artery is the last branch of superior mesenteric artery. I will draw now the new artery. The new artery located below superior mesenteric one. In my picture, it is the 13th one. We call it inferior mesenteric artery. In the brackets, write, please. It is the level of L2. If superior mesenteric located in L1 and truncus and soleacus located in T12, L1. Inferior mesenteric located in the level of L2. Remember, please. L2, L1, T12, L1. Is it understandable? Hamza, especially for you, once again. L2 level, L1 level, T11, 12 levels, approximately. Idea is understandable for you. Very well. Now look at please. From artery 13, providing one branch into the descending colon and divide it again into two branches, one to up, second to down. And now, guys, put here the number 14, call it the left colic artery, and put very big anastomose in the level of the left knee. and call this anastomose the Riolan's arterial arch. Riolani is the Italian surgeon who described it. The Riolan's arterial arch. Why this anastomose is big? Because it is functionally developed. What does it mean? For example, if one from these two arteries will be damaged, supplement of the left knee will not be destroyed. Another artery will absolutely not the supplement of all these huge middle colic arteries, but supplement of the left knee. So left knee, we can say that it is equally supplied by both these vessels. In right knee situation, another. Right part by one artery, left part by another artery. And this anastomose will not be enough to supply all right knee if one from these two vessels will be closed. Do you understand it or no? Natasha, you understand it or no? Let's continue. Now, next vessels, which is started from 13, it is 3-4 vessels, which is descended down to sigma. Sigma is intraperitoneal organ. They enter inside of the mesentery of the sigma, and what is important, inside of mesentery of the sigma, they form two or one arch, not 3-4 like previously, but 2-1. And they finally become to the sigma and supply it. But what it gives for us, if we need, we can make portional resection of the sigma, like for small intestine. That's why we will ligate its straight vessels, and according to them, we will remove the part of the sigma which is need to be removed. For the colon, we cannot do it. Let's continue. The finally next last branch from 13 become to the superior portion of the rectum, and it will be in my picture artery number. This rectum sigmoid is 15. That's why this is 16 one. We call it superior mesenteric artery. Superior rectal artery, sorry. Open the brackets and write, please. This is last branch of inferior mesenteric artery. By superior rectal artery, inferior mesenteric is finished. Now let's continue. What about middle third? And what about lower third supplement of the rectum? Everything is simple. Now look at it. Middle third supplied by vessels which is come from internal iliac artery, 5 in my picture. It is arteries number 17. And what is uniqueness of it? Double vessels. Before we see single vessels. Now you see double vessels. And call them 17, we call middle rectal arteries. Middle rectal arteries. Lower third become again two vessels. 1 minute. It is 18 arteries. Inferior rectal. And in the brackets write, please, this is the branches of internal pudendal artery, which is from internal iliac. Arteria pudenda interna, one of the main vessels in your pelvis, which is supply the urinal organs, which is supply genital organs, and which is supply the lower third of your rectum in the region of the anus. That is all supply of the lower third. Let's say 1 minute attention into this picture. This is the venous drainage. Generally, you know, guys, that from all gastrointestinal tract, now look, except this, except middle and lower portion of the rectum, from all other places, blood will be drained into this big blue vein, which is called portal vein. As I remember, please, from all gastrointestinal tract, except lower 2/3 of the rectum, blood will be drained into the portal system. How it is drained? According to the arteries. Arteries start from the splenic one, veins will be drained into splenic. Arteries start from superior mesenteric, veins will be drained into superior. Inferior. There's only one exception we have. In the lesser curvature of the stomach, we have two veins. Yeah, it is right and left gastric veins. They joined to each other, they form the vena coronaria ventricular, which is exactly drained into the portal vein. Not in the splenic, not in the superior mesenteric, not in the inferior, exactly into splenic vein. Finally, these three veins, in my head, will be pancreas. These three veins behind the head of pancreas, three veins, I mean splenic, superior mesenteric, inferior, joined to each other, and they form the portal vein. Portal vein goes to upwards, and above the pancreas, it is entering inside of the hepatoduodenal ligament between the duodenum and between the hilum of the. And here, as you remember, we have DVA. It is the portal triad. As you can see by color, it is ductus choledoch, vena porta, arteria hepatopropria. They come up to hilum of the liver, and usually inside of the hilum, each one divided into two terminal branches. Sometimes portal vein can be divided inside of the liver tissue. According to portal vein division, we make the segment or division of the liver. Finally, 8 segments, as you remember. First of all, right and left, then each one divided into 4. 4 in the right, 4 in the left. Questions? If no questions, attract your attention into this rectum. Rectum, it is one of the places of formation of portocaval anastomosis inside of the abdomen. How it's happened? I tell you 2 minutes before, superior rectal artery originated from inferior mesenteric. That's why venous blood will go into inferior mesenteric vein, which is drained into the portal one. Vice versa, in middle and lower third supply from internal iliac artery. That's why veins will be drained into internal iliac vein, which is belong to the inferior caval venous system. This is the region where we have formation of portocaval anastomosis. By the way, they will be located in 3 levels: under the serous coating, in muscular coating, and in submucous layer. That's a 3 main venous networks will be formed here. By the way, you know the disease which is called hemorrhoid.
Yes.
It is enlargement of these veins and possible bleeding from these veins. Cause of the hemorrhoid is different, starting from special professional diseases, drivers, long time sitting persons. The longer you sit, the worse will be drainage of the venous blood. This venous blood will be accumulated and will form finally enlargement of the veins. We can remember what varicose disease, yeah? For example, why pregnant women usually have it? Because inside of peritoneal cavity there are high pressure. Main veins is pressed, venous blood, you understand, from lower extremity is very problematical generally to drain the venous blood. Why? Because it is opposite to the gravity. That's why these veins, you know, they have semilunar valves and muscular constrictions, yeah, to press the blood to upwards. But anyhow, if there are high pressure, or for example, some sportsmen, which is take something heavy, yeah, it is also make the increasing of the pressure and also can make the varicose or can make the hemorrhoid. But there are one case of hemorrhoid which you must detect it anytime. It is portal hypertension. We say that this is portocaval anastomosis if your patient will have, for example, hepatocellular carcinoma, cancer, or will have cirrhosis of the liver, it also will give the hemorrhoid. Because blood cannot be passed into the portal system, it will shunt it into the caval system and will enlarge these veins. That's why much more usually we have not so much serious cases of it, and how we treat it. Surgically, we cut these hemorrhoidal structures and remove. But of course not in the case of the portal hypertension. You understand me or not? Second, by the way, place of the portocaval anastomosis, I will explain you now before to start to speak about stomach topography. Now, minute attention here. This is the second place of portocaval anastomosis between stomach and esophagus. You know, inside of esophagus, we don't have any absorption. Let's say we don't need to provide blood into the portal system. From esophagus, blood goes to the caval system. From stomach, of course, it goes to the portal system. One more place of portocaval anastomosis, border between esophagus and stomach. Now let's speak about stomach.
I have one question, sorry.
Please.
For hemorrhoid, after the infection of this veins, they will develop in future? to supply the,
Connected with the causal. Usually no, if it is again, I say you, connected with simple inflammation here, or it is connected with professional problems, high risk